So today we'll talk about the tumors of blood vessels and lymphatics. Now, these tumors are divided into tumors that are derived from the endothelium, tumors derived from helper cells, and they could also be primary tumors of large vessels. Primary tumors of large vessels are usually sarcomas like intimal sarcoma, fibrosarcoma. Anyway, how do we go about this question? Now, a lot of tumors of the blood vessels and lymphatics kind of overlap because most of them are derived from the endothelium. So you can divide this question into pseudotumors, benign tumors, and malignant tumors. So we'll start off with pseudotumors. Now, in the name pseudotumors, they mimic tumors. All of these are types of vascular telangiectasias, which are just local dilation of pre-existing vessels of the microcirculation. Now, the most common one, the most common ectasia is nevus flammeus, as you can see in this picture. It is a dilation in the dermis. It presents with pink to purple flat lesions on the head and neck that usually regress spontaneously around puberty. Port wine stain, on the other hand, is a type of nevus flammeus that grows with the baby. A lot of the times, it's part of Sturge-Weber syndrome, also called encephalotrigeminal angiomatosis. These present with ectasias in the trigeminal distribution, so you see it in the face or on the leptomeninges and so forth. Now, port wine stain does not regress. That's a big difference between nevus flammeus and port wine stain. The third type is spider nevi or spider angioma or spider telangiectasia. Now, these are just dilated vessels that form spider-like lesions. These are very, very common in patients with a hyperestrogenic state. It's common in pregnant people. It's common in patients with liver cirrhosis. The next one is hereditary hemorrhagic telangiectasia. So this is also called Osler-Weber-Rendu disease. It's an autosomal dominant disease, usually caused by mutations in TGF beta signaling. So the patients present with a lot of vascular malformations at birth on the skin or mucosa of the GIT, the urogenital tract, the respiratory tract. These lesions may rupture spontaneously, leading to a lot of bleeding. These patients will present with epistaxis, GI bleeding, hematuria. The last type I want to go through is bacillary angiomatosis. You've probably done this in micro. It's a vascular proliferation in AIDS patients due to gram-negative Bartonella henselae or Quintana infection. These patients also present with red papules or nodules on their skin. Okay, so let's move on to benign tumors. So benign tumors are usually hemangiomas, or in the case of lymph vessels, lymphangiomas. So first we'll talk about hemangiomas. Hemangiomas can be divided into capillary hemangioma, juvenile hemangioma, and cavernous hemangiomas. Let's talk about capillary hemangioma first. So these are the most common. They cause pink to purple lesions on the skin or mucous membranes. Could also appear on the kidney and spleen. Histologically, they show a mash of capillaries. There's a lot of special subtypes of capillary hemangioma. So firstly, we'll talk about pyogenic granuloma or lobular capillary hemangioma. These usually occur after trauma or during pregnancy, in which case it's called a granuloma gravidarum. These grow very rapidly, but usually regress. Some may need excision. Cherry hemangioma, on the other hand, is a benign tumor of the elderly. They don't regress, and their frequency increases with age. The next type is juvenile hemangioma or strawberry hemangioma. This occurs in newborns, grows over time, and regresses spontaneously by ages 5 to 8. They could also occur on the liver, spleen, kidneys, along with the skin. The last type, cavernous hemangioma, are larger, cavernous, interconnected dilations filled with blood. These may undergo thrombosis, they're more infiltrative, they're more locally destructive, and they do not regress. They're usually not dangerous unless they occur in the brain, and they're associated with von Hippel-Lindau disease, which basically causes multiple cavernous hemangiomas, also called hemangioblastomas, to occur in the retina or in parts of the CNS. Now, the lymph counterpart, lymphangiomas, they also arise from endothelial cells, but the difference is they're filled with lymphatic fluid, and if you do a biopsy, you will not see any RBCs in the fluid. Now, these, similarly to hemangiomas, can be divided into capillary and cavernous hemangiomas. Capillary hemangiomas are small, 1 to 2 centimeter, present as fluid-filled like blisters on the head or neck. Cavernous lymphangiomas, are pretty rare. They're also called cystic hygromas, usually associated with Turner syndrome, where you might see large lesions on the neck. The last benign tumor I'll talk about is a tumor that's derived from helper cells, specifically in this case, glomus tumors. Now, glomus tumors are derived from modified smooth muscle cells of the glomus bodies. These structures are involved in thermoregulation. These lesions are very painful. They usually occur under the nails on the nail bed. That's it for benign tumors. Now we'll go through the most common intermediate grade tumors, Kaposi sarcoma. Now, Kaposi sarcoma is a vascular tumor due to HHV8 infection. It's actually the most common malignancy in AIDS patients. It's a lot of types, so we'll just quickly mention them. The classical type usually occurs in people from the Middle East or Europeans. These lesions are usually just confined to the lower extremity and rarely disseminate. Endemic African type occurs in children or young adults. It can cause generalized lymphadenopathy and has a pretty poor prognosis. Transplant-associated Kaposi sarcoma is usually in patients that are infected by HHV8, but these these symptoms only really flare up during immunosuppression and usually regress once the immunosuppression is lifted, once the patient is not immunosuppressed. The last type and the most aggressive form is AIDS associated, which is, like I said, the most common HIV related malignancy. So you should know this. And I'll just talk a bit more about this on the next slide. Right, so pathogenesis. Usually it's due to cyclin D and VEGF dysregulation. These tumors can also gain a p53 mutation. They present as red to purple macules that over time progress into larger nodular lesions. Again, they start in the lower extremities and progress proximally. Histologically, you'll see dilated, irregular, spindle-shaped endothelial cells. Couldn't really find a picture, but you can Google it and see it for yourself. Now we'll talk about malignant tumors. Again, there's just two types, angiosarcoma and lymphangiosarcoma, which is the lymph counterpart. Angiosarcoma is highly malignant, highly aggressive. Patients with angiosarcoma usually have a very high mortality, occurs on the skin, soft tissues, and the liver. Skin involvement is commonly in the elderly in sun-exposed regions, or could also occur as a complication of breast cancer treatment. Hepatic angiosarcoma, on the other hand, this is very important to remember, associated with carcinogenic exposure to PVC, arsenic. You can also mention torotrust, which is a radioactive contrast agent, which is not really used anymore. Now, lastly, lymphangiosarcoma. All you need to really know about this is that it classically presents as lymphedema of the ipsilateral upper extremity, usually several years after a mastectomy is done for breast cancer. Well, I hope I covered everything for this question. Thank you for listening.